Hey everyone, it's Dr. Towfigh. Welcome to Hernia Talk Live, our weekly Q&A session held every Tuesday. We call it Hernia Talk Tuesdays. I'm Dr. Shirin Towfigh, your hernia and laparoscopic surgery specialist, joining you live from the Beverly Hills Hernia Center. Many of you are joining me via Zoom. Some of you are here via Facebook Live from @Dr. Towfigh. And thanks to everyone who follows me on Twitter and Instagram @HerniaDoc. So I'm really excited about today's session because it's all about your stories. And those of you who've been following me and know I love stories. I feel that the beauty of what I do is partly because of all the stories that I hear from you all. And you may know that I have a podcast that I co-host as the official podcast for SAGES, the Society of American Gastrointestinal and Endoscopic Surgeons. It's a great podcast if you want to listen to it. It's called SAGES Stories. And the reason why we named it SAGES Stories, because I feel everyone's story is so important. And that specific podcast is focused on surgeons' personal stories as they relate to SAGES and their laparoscopic endeavors, but also their personal stories. But specific to you all, you may have heard me say that the story is the most important factor of whatever medical diagnosis you're coming to me for. So when you come to me, I'll just give you a scenario. You come to me in my office. If you come to see me in person, you meet my front office, you check in, you get your vital signs, etc., and then you meet my nurse. She is the #1 nurse in the world, Belle, Nurse Belle. Many of you already know her. She is the most skilled hernia specialty nurse in the world, for real. It's all she does. She knows so much. But she gets your story and a lot of your intake and comes to me first before I see you. And I often know exactly what's wrong with you before I meet you, before I see you, because of your story. You tell me your story, and that is very telling as to what your diagnosis is. And mind you, my practice, as you know, is highly specialized in not just hernia repairs, but treating hernia-related complications. So most patients come to me with prior surgeries or prior imaging, prior consultation with other doctors. It's not just a straightforward, oh, look at this belly button hernia, come and fix it. And despite that, the story itself is so helpful. Patients come in with stacks and stacks of CDs, of CAT scans, MRIs, ultrasounds, multiple operations, but it's really, of all that information, your story is the most important. I kind of had a very rough week last week. I would say the last 2 weeks have been pretty rough because the stories that you've shared with me, whether it was via in-person consultation or what I call online consultation, where it's a less interactive but equally effective way to reach me, they really affected me. And I felt that there was so much sadness in these stories because I was talking with patients. I knew immediately, based on their story, what was wrong, or at least what needed to be done. And yet these were mostly young patients, some of them older, with some of them decades of chronic pain, unsolved medical mysteries, no reason for their symptoms, been told there's nothing wrong with them. And so for years, they are in pain. Some of them are in school and cannot go to class. They have to do their Zoom classes while laying in bed. Many of them had to quit their jobs. Some of them are married and the problems affected their relationships. I have construction workers that can no longer work and are on state disability. One patient came to me wheelchair bound, and that story has really affected me. And I desperately hope that I can cure that patient and get them back walking again. It's just been a rough 2 weeks. The stories were just so heartbreaking. And I just want to share with you some common themes. The most common theme is there's really something wrong with a patient. There's a reason for their symptoms or their pain or their symptoms. And they go from doctor to doctor and they're told there's nothing wrong with them. They're told they have to live with it. There's imaging is all normal, not true. Their exam is normal, not true. They didn't get the right exam. They didn't get the right imaging. And they're told nothing wrong with you, nothing we can do. Oftentimes the patients get this full gaslighting. So then they start thinking, maybe it's all in my head. Maybe there really isn't anything wrong with me. I'm just feeling things. And that's a situation you should never be in. What my impression is, and we'll go through some of your stories because many of you have shared your stories. I will definitely respect the time for that. But I feel that the common themes are patients that are legit going to their physicians, whether they're doctors or surgeons or some of their PAs or nurse practitioners, and they are told that what they're feeling or what's going on with them either doesn't exist, it's misinterpreted by them, they may be lying about it. That's not as common, fortunately. Nothing to do, it's all in your head. You gotta live with this for the rest of your life. Here's some medication. I mean, I literally had a teenager who was told there's nothing to do. Here's some gabapentin, which is a nerve modulating medication, which A, has side effects, and B, makes you very drowsy, and just take it. And the implication is you have to take this for the rest of your life. She's a teenager. I mean, how ridiculous is that? Athletic, could no longer do athletics, couldn't go to school. So this is a situation where, fortunately, most of the people that came to me are their own best advocates. Even some of them have been told for years there's nothing to do, and yet they still follow their gut. They know deep down there must be something wrong, and they reach out. And I'm so glad that they did, because there are probably multiple times more patients out there that lose hope. They feel that there's nothing they can do. They believe the scenario that nothing can be done or there's nothing there, and they live with it. I think the one who broke the record was 22 years of pain. They just gave up. And once I cured them, this was someone elderly lady, the son just broke down and couldn't stop crying because he had forgotten what it was like to see his mom walk without a limp. That's how bad the situation was. And she had a femoral hernia, by the way, uncommon hernia, but definitely one that women are more prone to. You've heard me talk about femoral hernias a lot on this show. And I fixed her, I diagnosed it, fixed her hernia. She's normal now. And the son just lost it in front of me, like literally had forgotten what it was like for his mom to walk normally. Just, it was their new normal. So kudos to everyone who shared their stories with me, and kudos to everyone who believed in themselves and didn't take no for an answer. You know, in Hollywood, you know, I'm in Beverly Hills, so this is Hollywood. In Hollywood, there's a saying that no means not today, not yet. And you have to keep pushing and being resilient. And a lot of the movies we see and books that are published or projects that went through because of persistence. And let's say a screenwriter in Hollywood, for example, continues to push their screenplay until it finally gets a contract with some major production company. So you have to be the same. You have to be persistent. And if your doctor locally can help you, great. If they cannot, go outside your system, go outside your state, go outside your country. I see a fair number of patients both outside the state and outside the country. So it's definitely something that I highly recommend, because I feel that it's just not cool to live with the way that some people think it's appropriate to live. The other thing I wanted to make sure you understand is, oftentimes, if you're told there's nothing to do, it means that doctor cannot provide you with the care that you need. Doesn't mean you can never get the care that you need. It means that specific physician, surgeon, whoever doesn't know the answer. So you got to keep searching. And that's what I recommend that you do. I highly recommend everyone get more than one consultation. Many of you know that I offer what's called online consultations. So that is when I don't necessarily, I don't see you, I don't examine you, but you send me all your story. You send me your story, and these stories are just amazing. So I do want to share some of the stories. I know some of these patients myself, and I feel that I know I have some insight into their stories, but I'm glad that some of them shared it. I will share some of the stories from the past several weeks that have really affected me, that I hope you understand. I may change some details in it, so it's not exactly the same, the one patient or two patients that I saw with that story, but I hope it resonates with you. So I see that many of you are coming on live. Thanks for all your questions. Great topic. Thank you. We will be helping you. How many mesh excisions are performed per year? That's a good question. We don't know the answer to that. I know that 1 million hernias are repaired each year, but I would venture to guess, if I had to estimate, mesh excisions are probably less than 20,000, maybe even less than 10,000 a year. So less than 1%. You're one of the 5% that will always feel pain from a surgery. Yeah, some people are more prone to complications than others. Can I do core exercises if I have epigastric hernia that doesn't hurt or bother me? Yes, and we've discussed this before, that exercises are excellent for hernias and are not only protective, they should not make your hernias worse. So let's move on to some of your stories. Some of them are educational, some of them are still in the process. And pardon me, I'll be reading a lot of these, so gotta pay attention. Okay, this all started with a foolish lifting accident that led to what was diagnosed as multiple injuries in my groin, causing pain and discomfort, including having had successful hernia repairs many years later. Number one, left incisional or indirect hernia through a reconstructed deep inguinal ring. Number two, attenuation of the floor of my previous multi-layer inguinal canal repair. Usually we call that a direct inguinal hernia. Number three, recurrence of a previous right-sided mesh repair due to tearing of the medial attachment. And number four, all accompanied by bilateral disruption of a prepubic aponeurotic plate. So one thing I want to suggest is, these are all very complicated things we're talking about, but there's a difference between a sports hernia and a regular hernia. And we have had at least 2 prior HerniaTalk live sessions, one with the Vincera Institute and Dr. Poor, talking about sports hernias. And sports hernias specifically are not your traditional inguinal hernia. A sports hernia has to do with disruption of the natural attachments of the muscles to the bone, or tearing of the muscles, whereas hernias occur in naturally occurring parts of the body, such as the inguinal canal or the transversalis fascia. And those tend to be different in nature. Their symptoms are often different. The reason why you get it is different. The type of patient that gets it is different, etc. So many times I see a housewife or elderly patient diagnosed with sports hernia. It's just not possible. You just can't. You don't have this muscle strength or the force to get a tear like that. You must be in sports, so athletic in some way, and have the structure to be able to tear it. Also, I must say that the diagnosis of sports hernia is often incorrect because they don't see or feel a typical hernia. So the default is, oh, it must be a sports hernia, but you have to have some logic to this. How do you get a sports hernia or a tear if you don't really have muscle tissue that's that strong, or you didn't do any activity like that? The one exception is trauma. You can get traumatic hernias. Those are very different. People that fall tend not to get sports hernia type symptoms, but a big car accident can cause traumatic hernias. Again, that's different from a sports hernia. So after intense research, which I must have got wrong, I underwent a bilateral repair that consisted of resecting herniated adipose tissue. Okay, that's a hernia. Coming through previously reconstructed internal ring. Okay, that's a recurrent hernia. And tightening of loose previously reconstructed internal ring. We usually do not do that because tightening of an internal ring, unless it's part of a tissue repair, does cause tearing and chronic pain. Number 2, imbrication of weakened previously reconstructed left inguinal 4. That's basically a direct inguinal hernia plication. So if you have a direct inguinal hernia, you'll be plicated. Closure of the right-sided hernia defect using a small piece of Ultra Pro mesh. Okay, the fact that it's small is not a good thing. You need to have the standard size of mesh. Smaller meshes are more likely to be tight and cause recurrence. The mesh was fixated to Cooper's ligament because of attenuation of the inguinal ligament. That's also not standard. I don't understand why you would do a retroperitoneal mesh when you're doing an anterior approach. Fixating the pubic plate down to the deep pubic periosteum. That's to address a sports hernia, which I'm not sure this patient had. Suturing of the lateral border of the rectus muscle to the inguinal ligament and tenotomy of the adductor longus consisting of multiple incisions. Again, these are multiple operations done for a typical LeBron James type sports hernia, which very likely this patient did not have. Following my surgery, my pain has been more intense. I told you, because multiple things have been done which cause increased pain. The tightening of the internal ring, the closure, the use of a small piece of mesh. The Ultra Pro is a very, very lightweight mesh that often doesn't work, especially if you have a direct hernia. I will need more extensive workup to determine the cause of the increased pain and whether another surgical intervention may be appropriate. So usually these require either undoing of the prior repair to make it looser and putting in a retroperitoneal mesh, or just treating a reconstruction, recurrent hernia. The patient story also includes cryo, radiofrequency, and surgical neurectomy. I don't hear anything in the story that tells me there's any nerve pain going on. So that's another thing I'd like to talk to you about. Nerve pain. So we've had 2 pain specialists come on. We have another one coming up really, really soon, which will be an amazing discussion. But when you have nerve pain, there are multiple modalities to treat it. But pain is not always nerve pain. In fact, most groin pain is not nerve pain. And I see so often a surgeon sees a patient, oh, you've got pain, go see the pain management doctor. Pain management doctor understands nerve pain. They deal with spine disorders, etc. And they keep doing nerve blocks and cryoablation and surgical, recommend surgical neurectomy or put in nerve stimulators for the spine. But the pain is because your hernia is recurred, or the mesh is folded, or it's too tight of a repair, you're tearing. So it has nothing to do with the nerves. So please, please, please do not touch your nerves if there's nothing wrong with them. Okay. Here's a question. How do you repair a defect in the fascia as opposed to a hernia? So if you have a full thickness defect in the fascia, which includes the full muscle, etc., communicates the front from the back, that is that by definition a hernia, and you do a hernia repair. If you actually just have a tear of the fascia and the muscle underneath it's intact, that's usually a sports type injury, and we just close the fascia and rarely need to use anything like mesh. Got some more stories for you. So here's an example of a patient that is being given all this information. It makes it sound like this complicated situation was going on, whereas probably what they had was an inguinal hernia that required repair. And yet there's all these like, pubic plate, aponeurotic plate, and, things were tightened and imbricated, and it's giving a lot of complexity to an otherwise simple situation. And now that they have pain, they think it's also a complicated situation. Often it's not. Here's another story. I had a femoral hernia that Dr. Towfigh diagnosed. Great. Without her help, I believe I never would have gotten a true diagnosis, which led me to have a femoral hernia repair. Nice to hear. I lived with horrible growing pain for 10 plus years. That is horrible. 10 plus years of growing pain. And now I am 85% better since having had surgery. I would have still been suffering had I not found Dr. Towfigh. Okay, so thank you for that story. Femoral hernias are classic for this. People cannot feel femoral hernias. It is a rare problem to begin with. Most doctors don't even think about it as a diagnosis. It's more common in women. It's often misdiagnosed. And in people who have it, they may have another hernia as well. So they have the regular hernia repaired, and they totally do not get the femoral hernia repaired. And so after surgery, they still have chronic pain. It's actually the #1 reason for women having chronic pain after a routine hernia repair is a missed femoral hernia. So that was in the day before laparoscopic surgery. So yes, femoral hernia should always be in the differential diagnosis. I also see some really very unique, like really rare hernias. So there's these perineal hernias, the rarest of which is a sciatic notch hernia, and I've repaired those before. There's perineal hernias and obturator hernias, and these weird like posterior lumbar hernias. So I think they're cool because I get to operate on them. Very, 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 very rare. Incidence is like a fraction of a percent in the world. But because I have that experience, every time I look at an imaging, I also look for those. You never know. Maybe their pain is from that. In fact, I'll give you a story. Okay, great story. Lovely lady, many, many years of pain, to the point where she can't sit. Like it's just difficult even to sit. She has to use a donut. And she has this kind of pulling pain in her lower abdomen, and she gets some bloating with it. Anyway, long story short, sees multiple doctors, even goes to like these major institutions, Mayo Clinic, etc. And they tell her nothing wrong with you. Maybe it's your back, it's not your back. Pelvic floor, it's not pelvic floor anyway. So because I have this experience where I've treated these really rare pelvic hernias, when I saw her, I looked at her imaging, and in addition to looking for regular hernias, I looked for these really rare hernias. And guess what? She absolutely had one, perineal hernia. So perineal hernia is a very rare hernia in the muscles of your pelvic floor. It's often there because you've had a very traumatic pregnancy, but not necessarily. It can actually occur spontaneously. I've not seen any in men. They've always been in women. And I believe it would be super rare for a male to have it. And her imaging didn't really show it except for one image. I'm like, listen, you need to get imaging with Valsalva, bear down imaging. Because how do you get most of your imaging? You're lying flat. What's the best way for hernia pain to go away? You lie flat. So we don't really do stand-up imaging. There are stand-up MRIs, but they're not very high quality. So to reproduce the gravity pull of standing and abdominal pressure of standing, we have you do bear down views, bear down during the imaging. So she had a bear down imaging. Lo and behold, little piece of colon got stuck in this little itsy hole in her perineum, and it got missed actually by radiology. So I called the radiologist. I'm like, hey, dude, buddy, I don't want to tell you how to do your job because I respect you. You're a radiologist. You're really great. But I'm looking at image series. I'm going to make this up. Series 9, image 54. Doesn't that look like a perineal hernia? He said, you're absolutely right. Oh my God. Do you need a job? I can hire you in our radiology. He literally told me that. Of course he was joking. I have a job. So I diagnosed it. Now, she's from out of state. It's hard to have surgery in a different state. I understand that. So she went back. I hooked her up with one of her surgeons near her. Asked in advance, have you ever treated these? Yeah, we've done this before. Honestly, I'm not so sure because she saw that surgeon. That surgeon completely said, nope, don't think that's it. Maybe it's a nerve, which of course it's not. And took her down this whole like rabbit hole of nerve pain. She called me back. I said, oh, no. It's all about your story. This is not a nerve issue. You can't sit. Standing up for a long time bothers you. It affects your bowel movements. This is a perineal hernia. Call the doctor again. Hey, buddy. Listen, I don't want to tell you how to take care of your patients, but look at this imaging. Look at this here. Listen to her story. This is a perineal hernia. You told me you know how to fix these. Guess what? She's scheduled for surgery. So the point is, it's all about the story and not really being able to see or examine the patients and get that story is not helpful. All right, next question. You know my story, growing pain that became abdominal bloating, pressure, edema, and cold burning, searing sensation up my spine, all due to nerve damage. Yeah, so I'm happy to help you. We're going to reassess everything I know you've been talking to Nurse Bell. So I'm happy to help figure this out for you. Next question, what kind of mesh did you use in that femoral repair and what was the size of the mesh? Okay, good question. So the gold standard for femoral hernia repair is a laparoscopic repair with mesh. The type of mesh you use is not very relevant, depends on the patient. You can use lightweight mesh, you can use heavyweight mesh, you can use midweight mesh. It really doesn't matter, unless it's a huge femoral hernia, which it almost never is. In the really huge hernias, you maybe use more of a midweight or heavier weight mesh, not such as a small weight mesh. The typical size of mesh depends on the size of the patient's pelvis. It usually starts at 10 by 15 centimeters, or I say it's like the size of my hand. And that's the mesh, because you not only fix the femoral space, but you also fix all the other areas. We call it the MPO or myopectoneal orifice. It includes future inguinal hernias. Another question, what type of imaging shows the mesh end plug used in a left inguinal hernia surgery? So all imaging should be able to show those. Ultrasound, CT, and MRI will show you a mesh plug. However, if you really want to get the best information in planning for surgery and evaluating that repair, I recommend an MRI without contrast. Okay, let's go through another story that was sent to me. Oh, going back to this femoral hernia situation. So I posted on this multiple times and shared some stories. In fact, I don't know if any of you guys are follow Beverly Hills Housewives of Beverly Hills, but Denise Richards had a femoral hernia, which I repaired, and she also had a problem getting diagnosed for a really long time. She was really great at sharing her story. So not everyone gets femoral hernias, but it's definitely something to look out for if you have enigmatic or mystery growing pain. Okay, here's another story. I was implanted with Phasix ST mesh. So that is a synthetic absorbable mesh. And the ST stands for Seprafilm technology, which implies an anti-adhesive barrier, which means this is an abdominal wall hernia. So I was implanted with Phasix ST mesh for hernia and muscle repair. I was disabled from it from day one with pain and autonomic nervous system dysfunction. That usually means POTS, postural orthostatic tachycardia syndrome. I did not want synthetic mesh, and the implanting surgeon agreed to use biologic, although technically this is not biologic, it is synthetic. I've since learned that Phasix is a hybrid that has polyester in it. Not exactly accurate. Phasix is not a hybrid. It is a synthetic absorbable mesh. Hybrid meshes imply there's a that there's a absorbable and non-absorbable component. This is purely absorbable, but it is synthetic. And it doesn't have polyester in it, but it does have a type of product in it which is closely linked to polypropylene, but it is absorbable. From high functioning, I wound up bedbound. I had developed a small bulge in the lower flank that I was told was a hematoma that would resolve. 4 months later, mesh was removed, but the damage had been done. I now have full-blown dysautonomia, POTS, and MCAS. So POTS stands for postural orthostatic tachycardia syndrome. MCAS stands for mast cell activation syndrome. They often come together. Some people also have Ehlers-Danlos syndrome. And a little tidbit, in a couple of weeks, we're going to have a specialist on all of these discussing how they're interrelated for you all to learn from it. Some women also have endometriosis as part of this syndrome. So just so that you understand why this is relevant, so patients that have mesh in them that's synthetic, and I don't care what kind of synthetic, absorbable, non-absorbable, there is an inflammatory process as a result from it. The more synthetic the product, the more inflammatory. And that can, in very few patients, but in some patients that are prone to it, spark a autoimmune or inflammatory syndrome of sorts. We call that Asia syndrome or Schoenfeld syndrome. We've had Dr. Trevert in the past talk about it, and we have upcoming guests who are also specialists in this process and came up with this diagnosis to talk about with you all. But it's unclear if POTS and MCAS, which is mast cell activation syndrome, which are both autoimmune and or inflammatory disorders, it's unclear if that is sparked by the mesh or if people have that and they get a reaction from the mesh. So in this situation with this story, the timing of it seems like they were doing normally fine and the mesh sparked this problem. The thought is that once you remove the mesh that this dysautonomia will go away, but sounds like it hasn't. So she also has a denervated abdominal wall. That seems not right. I've spent the last 2.5 years trying to regain some functionality and have seen many specialists and have discussed surgical intervention for the abdominal wall. So here's the issue here. The POTS of the MCAS prevents you from having any synthetic mesh, absorbable or non-absorbable. So you're relying on a non-mesh repair. In some situations, you can have a biologic, high quality biologic that's low in inflammatory potential used to augment your tissue repair. I would like to know if you also have Ehlers-Danlos syndrome, because that goes with the two. And then the question is, why do you have this denervation? Because if you have a denervation, even if you have a tightening of that loose muscle, it will fall apart as a very difficult situation with not that much you can do about it. Very, very difficult situation. You're one of 2 patients I know with this problem. Next question. When you do laparoscopic surgery, how many tacks do you use and where do you place it to avoid pain but still keep the mesh in place? Great question. First of all, if you don't always have to use tacks, number one. Tacks are some type of fixation, whether it's a curly Q or a suture or something. They're either absorbable or non-absorbable. I prefer the non-absorbable because there's little to no evidence that an absorbable is any better. But we do know that it's long-term results are better with non-absorbable fixation. So where do you put it? First of all, use as few as possible. I had a patient, she had, I think, 19 tacks placed just in one groin alone. You should have like 3. Anything over 5 is definitely egregious. 19, I just don't understand. And this was for a groin hernia, laparoscopic. She was dragging her leg, I should say. She was dragging her leg after surgery for 3 weeks. She went to her doctor and the doctor was like, yeah, it's fine. You'll get better. Just keep walking it out. And she's like, I literally cannot walk it out. Eventually her leg function improved, but she still could not totally bear weight on it. And she had severe right lower quadrant pain. And she saw me and I'm like, you have 19 tacks. And guess what? Many of them were placed in correct places. So you don't want to put any near the nerves. She had multiple around the femoral nerve, which is completely incorrect placement. You should not put any near any nerves. In fact, we call the area of the nerves a triangle of pain. So the inguinal, iliohypogastric, genital femoral, and the lateral femoral cutaneous nerves should not be anywhere near those fixation areas. You should not put it into any critical structure like a vessel, external iliac vein, external iliac artery, epigastric vessels, or like the bladder. Don't put it through the bladder. But other than that, it's pretty safe to put through muscle. And we don't like to put it too deep in the muscle because that can be too tight or too painful, and there are nerves in the muscles. So there's a delicacy to using fixation. You don't overuse it and use it in correct places. And when you place it delicately. Let's see. Oh, why no contrast for the MRI? Because it doesn't help you. The contrast has no, there's no indication for using MRI with contrast for patients with soft tissue problems. Next question. I believe my mesh has pulled in at least 7 suture points on the right side of my umbilicus. Is removing just those sutures a good fix, or should the mesh be trimmed or be attached, or just have it all removed? It is a 4.5 centimeter patch. Let's see, 4.5 centimeter patch over the belly button, at least 7 suture points. That seems like a lot for 4.5 centimeter patch. So it depends. If the pain is exactly where the suture is, you can just take out the offending suture. If the pain has to do with too tight of a repair overall, then you need the release of all the mesh and the sutures from that area. My surgical report says the ilioinguinal nerve was not preserved. Could that be causing all my pain? Depends, again. So if you already had ilioinguinal nerve problems and that nerve was cut, there's a risk that you're going to have recurrent problems in about 5% of the time. If you had no problems with the ilioinguinal nerve and it was cut prophylactically, in our study, surprisingly, we showed no problems with that. 0% had chronic pain or any risk in doing so. But you would maybe be numb in the area. But in order to figure that out, it's all part of your story. Where do you have burning pain, hot poker? Is it in the same direction as the ilioinguinal nerve? If it is, then probably the nerve could be causing your pain. Again, it's all about your story. Can the rectus muscle fascia be a source of pain if sutures are placed in the rectus muscle? Full thickness, yes, it can be. Yeah, the muscle tends to tear as opposed to fascia. So if you're tearing, oftentimes it's not the suture, it's just the tearing effect. So a lot of people come in and they think, oh, they got nerve pain or something. They don't. They just have too tight of a repair, and the repair is trying to tear. And it's that tearing sensation, that tearing effect that causes their pain. So what do you have to do? You got to fix it. Either take the tension off undo the repair, or more importantly, just like do a better hernia repair to take the tension off the original repair. More questions. I had 2 hernias when I had surgery. I have chronic pain, heart problems, pulmonary problems, intestinal problems, kidney problems, etc. They would not do removal surgery on me. Mine was put in 2001. So obviously the the mesh removal surgery needs to be performed without killing you. It's definitely a risk-benefit ratio that your doctors will have to take. So if they feel that the operation is way too high risk for the symptoms that you're having, then that's the decision between you and your surgeon. Next question, what are the symptoms and causes of pain after prior tissue repair that you see in your practice? Good question. So there is a lot of risk with chronic pain after a tissue repair. The most common is the tissue repair falling apart. It doesn't fall apart, it tears apart. So you're actually tearing your muscles and your tissues as part of the recurrence. And when you're tearing, that implies that it's going to be very painful. So the same way LeBron James's rectus muscle tear is very painful, or groin strain is very painful, a tissue repair tearing has a similar pain. And that's why people have symptoms. So I just recently operated on a patient. No one could figure out why they had pain. Nerve injections. Finally, they said, you got to do a stimulator. Guess what? The nerve injections never helped. So the 2 options are, if you're tearing through muscle, use some Botox and relax that muscle. If you can relax the muscle and the pain goes away or is better, then it's too tight of a repair and it's trying to tear through. Sometimes imaging will actually show you the tear and also show you that there's a hernia that's trying to recur as a result of that tear. My incarcerated painful hernia, about 1.5 inches, even on lying down, but was reduced after 3 weeks to about pea size and only can be noticed with Valsalva. I don't know how, but do I still need surgery even if it's already reduced? So I highly recommend that you listen to last week's episode with Dr. Robert Fitzgibbons Jr. from Omaha, Nebraska at Creighton University. He is the author and father of the Watchful waiting trial. And that is where we discussed, the risks and benefits of surgery and how okay it is to just not operate on hernias, especially if you have no symptoms or minimal symptoms. Whether it's incarcerated is not as interesting. Next question, can tearing pain ever ease on its own, or does scar tissue keep growing and tearing repeatedly? Yeah, tearing keeps continuing. It doesn't stop. It doesn't stop. My story started with a femoral hernia repair, and the story continues. Happy that Dr. Towfigh is part of my story too. Yes, I know. And I can't wait to fix you. I don't know how I'm going to fix you, but I can't wait till that day. Can a very deep infection near the inguinal area cause neuralgia paresthetica? Okay, neuralgia paresthetica is a term for the impingement of a very specific nerve. The nerve is called the lateral femorocutaneous nerve. It runs under your inguinal ligament, which is like a wire. So in some people, when you stand, it kind of cuts on and impinges on the nerve. When you sit, it's better. So if you have true neuralgia paresthetica, that is an impingement on the nerve. Now, usually the impingement on the nerve is from the inguinal ligament, but in some patients, it can be impinged on by scar tissue. And yes, a deep infection near that area can cause scar tissue, and the scar tissue can cause symptoms of your lateral femorocutaneous nerve. She goes on to say, I've had the pain and tingling and unable to lift my leg high as to get in a car. I've been told a large ventral or incisional hernia as well as I've been told I have a large ventral or incisional hernia as well as an umbilical hernia. Okay, so you may also have an inguinal hernia, and this is not related to your lateral femorocutaneous nerve at all. But again, part of their story. So where is the pain? What is affected? Getting in and out of a car, that's usually inguinal hernia. Is it worse when you're standing than sitting? That's usually neuralgia paresthetica. So all these little details in the story are very important. Let's do another story. Oh, this is a long one. My name is Carol. In 2016, I had 12 inches of colon removed due to a perforation. During the surgery, they repaired an umbilical hernia. I was unaware of that to begin with. Because I was experiencing issues with the colon surgery, I was unaware I even had an umbilical hernia, nor had I been educated on exactly what I had happened to me. I recurred the incisional hernia repair. Okay, so she had an umbilical hernia. It was fixed during her emergency colon surgery and it fell apart. Actually, you had emergency colon surgery, which implies you're already at higher risk of an incisional hernia from the incision that they did to get to your colon. Very high risk. I think 30–40% risk of just an infection, and infections can cause hernias. In 2017, which is 1 year later, I needed my gallbladder removed. So the surgeon repaired the incisional hernia at the same time and placed a small piece of mesh inside me. Again, small is not better. Again, I was not aware of the mesh, nor was I given any education on self-care. So small is not good. When people say, oh, I just had a little hernia mesh put in, that implies usually that the mesh is too small, and therefore you're at higher risk for a hernia to recur. Okay, she goes on. So of course I recurred again. There you go. See, just from the story, I can tell you the next step of what's going to happen. Next, but my regular doctor and ER doctors told me that I was experiencing gastritis and to take Tums and antacids. Again, if you had a recurrent hernia and you had abdominal pain and it's worse when you're standing and bending, that's not because you have acid reflux. It's all about the story. Not until I was literally writhing on the floor in pain and we called an ambulance did they do a proper imaging and saw that not only I had recurred, but now it was strangulated. And strangulated means usually bowel is stuck in the hole. This was in 2019. So it sounds like you were probably having intermittent obstruction or bowel stuck in the hernia, causing you the pain. It was just missed. I was told I'd need to have my small intestines resected. Luckily, my colorectal surgeon had them wait, and after 4 days of lying in the hospital, my intestines popped back in, and they repaired me and sewed me up. I had a second piece of mesh placed. Again, no one told me about it, but that is part of the repair. Not until July of 2021 did I learn about hernia groups on Facebook, and people there instructed me to gain access to my medical records, where I discovered that I indeed had mesh inside of me, and I indeed had recurred a hernia yet again. Wow, that's 3 hernia repairs. 1, 2, 3. 2 of them with mesh. I have since dropped 53 pounds. That's good, because if you're overweight or obese, then that's a major risk factor for these hernias falling apart. And I've been able to consult with a few surgeons, including you, Dr. Towfigh. Yay, I hope I can help you. And I will be making my decision soon as to the next course of action. I have drastically modified my day-to-day habits of movement and also switched my sleeping position to back sleeping only. See, this is what a lot of people don't understand, is you have to change so much of your lifestyle to have to deal with these hernias. I squat instead of bending, and I'm taking big steps overall to not aggravate my current situation. Because having strangulated once and now that recurred, you may be at higher risk than the average patient from strangulating again. I'm thankful I don't have any big pain, and I'm praying this next surgery can remove the 2 pieces of mesh I have inside, and I can have a repair without more mesh, and it will be the last surgery I have. Okay, not to poop on your party, but if you've already failed 3 hernia repairs, you're definitely not going to have a tissue repair performed. But the question is, where are these meshes? How were they repaired before? Can we do a nice, beautiful repair with just the right amount of mesh and just the right placement, just the right area to get you to a point where there's your last operation, you don't need any more surgeries? And part of it is to go through your story and understand why like walk you through the story to understand why you recurred each time. Did you recur because you had a chronic cough and was constipated or were very overweight? Or did you recur because the surgeon used the wrong technique, the wrong size mesh, and the wrong thickness of mesh? Again, it's all part of the story. Next question. Let's see. I'm 62. I've had a very big hernia at the bottom of my stomach for years. I have colitis too, so it hurts. Even to bend, it hurts. The doctor doesn't think I'm healthy enough to have surgery. I need to lose a lot of weight. Could anything happen if I don't have surgery? It's very big and hard on both sides of the hernia. So the size of hernia is not as much of a factor as your symptoms. So if you have symptoms related to the hernia, you do need surgery. But before embarking on any surgery, make sure that you're not constipated, you're not straining, you're not overweight, and you're not using nicotine, and you don't have a chronic cough. Then you should have your hernia surgery. Do not try and just get it done just to have it done, because as you heard from this last story, she's had 3 hernia surgeries and looking for a 4th. You don't want to be that person. All right, when you have a patient with terrible pain from badly placed mesh and the mesh needs to come out, do you call the surgeon from the original surgery to let them know so they can understand the results? Okay, great question. So yes and no. I used to always call the surgeons and say, hey, so just let you know, I'm seeing your patient. I feel that this is the problem and I'm going to fix it. Just want to let you know. And 8 out of 10 times I got nasty attitude. It was like, they basically said, you're wrong. There's no way that my hernia recurred. There's no way that my mesh is causing the pain. There's no way I did anything wrong. And it was just the worst interaction. And so if the patient asks me to call their doctor, I do. But no, I do not call, I don't routinely call those doctors. If I know the surgeon personally and we have a rapport, I do. But I don't call them anymore. It's just a horrible interaction. I hate to say this, but in my experience, people, and I'm a nice person. I'm not like telling them and these things happen. I've had my own patient. I would like to know if any surgeons out there that has my patient, please let me know, because I want to know what happened, what they're going to do, etc. But I feel that's not the case for most people. I do want to share another story of someone who's been on a very active person on HerniaTalk. You've heard me. I have very few patients that I publicly talk about. Some of them have asked to come on or asked to share and be involved with their stories. The patient RN, the patient RN, who came on around Christmas time, she shared her story and also kind of how she was able to navigate the system to advocate for herself. I have a recent patient that, man, his life kind of really got screwed up after mesh was put in. And he went to doctor after doctor, chairman, department head of surgery, whatever. They all told him he's like nuts. It's all in his head. There's nothing wrong with him. He finally reached out to me. Again, online consult. So it's a great way to initiate a consultation. He's not from this country. And I think he wants to move to the United States based on his very positive experience. But I performed the operation he thought he knew he needed. He needed his mesh removed. He had a very significant mesh reaction. Mesh implant illness is what we like to term it now. And all of his symptoms pretty much have resolved. He's able to go back to eating normally. All of these weird rashes he had, and the joint pains, and the brain fog, inability to concentrate are all gone. His energy is up. His attitude about life is up. So people just didn't believe that he had a mesh reaction. And they told him, not only did they tell him he was wrong, there's nothing wrong with you, but they also told him there's nothing to do and that no one can do it, which was totally wrong and gets rid of hope for patients. I've had patients been told, you can't have this mesh removed, you'll lose a leg. Never happens. you lose a testicle. Almost never happens, or shouldn't happen in most situations. You'll never be the same again. Operating on pain causes more pain. All completely false. If you know the story and get the right history and come up with a very solid plan with the right doctor that has the experience, you should have a good outcome. And I'm not able to solve every single medical mystery, but I must say, pretty damn good with a lot of these. I kind of enjoy it. I really do enjoy it, to be honest. In fact, my patient today said, I heard you like mysteries, you like to solve mysteries. That's why I came to you. I'm like, yep, love mysteries, medical mysteries. Next question, next story. I had a colon resection on July of 2020. During the procedure, my small intestine was nicked and they closed it. Okay, that's a problem. It can happen for sure. But if you have any intestinal injury, the risk of you getting sick from it, fistula, infection is very high. Several days later, I became septic, which is a very deadly infection. A second surgery was done to fix it. So after 3 laparoscopic surgeries using my umbilical area, this resulted in a very large ventral and umbilical hernia. I'm still waiting repair. What could happen if I don't fix it? Okay, so this is a good question. In general, if you have no symptoms, we discussed, this should all be from last week. This should have been last week's question. We talked about watchful waiting last week. So the answer is this: if you have 0 symptoms, watchful waiting is considered safe, including for ventral and abdominal wall hernias. Are incisional hernias in the same category? We don't really know scientifically, but likely they are. Although incisional hernias usually imply more scar tissue than your typical umbilical or ventral hernia. So if you have minimal symptoms, it's often, and you live in like a country where you have easy access to emergency care, it's often safe not to do anything about it until you start getting symptoms. But once you do have symptoms, and Dr. Fitzgibbons was very clear about this last week, once you do have symptoms, it would be not the right decision, especially for ventral hernias, and especially if you're elderly, to just ignore it, because the symptoms are an indication that something is getting caught in there and the risk of problem is higher. Next question: how can you determine whether a tissue repair is too tight and is tearing? Clinical exam imaging, would that be the telltale signs to you? So it's your story. It's how to put what was seen, what was done, and what your symptoms are now together. Oftentimes, imaging is not a good way of assessing it. However, you can have Valsalva imaging, like an MRI with Valsalva, and see if there's not enough bulging, natural bulging from a tissue repair, or if it just like rock hard stays there from a mesh repair. So that's sometimes helpful, but not usually. It's all about the story. Keep saying it. All right. Let's do a couple more questions before we're done today. After my trial with the DRG pain stimulator, I have not been able to have a normal bowel movement without digital stimulation. What can cause that? Is it something to be concerned about? That's weird. So you should be able to have normal bowel movements because the pain stimulator is way up high. It's not sacral in nature, but potentially you may be on narcotics or other reasons that may be causing constipation and difficulty emptying. Your pelvic floor should also be able to be unaffected by the stimulator, because that's also sacral nerves, and that's usually not where DRG pain stimulators are placed. What are your thoughts on getting nerves burnt to stop pain after inguinal hernia repair? I don't believe in burning nerves for all inguinal hernia repair, because most inguinal hernia repair pain is not nerve related. So if it is nerve related, first I block it. Oftentimes it's all you need is blocking, or if it's involved in scar tissue, kind of doing a hydrodissection with hyaluronic acid. I had my plug and patch removed at the Cleveland Clinic in December after 10 years. See, good job. I didn't have unbearable pain until 2021 and no one could figure it out. It's been 5 months and I have done PT for 8 weeks. Plug pain is gone, yay. But now I get pain around the adductor insertion and pubic tubercle after activity. I did have a flat sheet put back in because I'm active and lived with mesh for 10 years almost pain-free. No nerves were taken. What do you think can be causing this new pain? It still prevents me from being active and pain-free. So, okay, so if you have, let's see, pain around the adductor insertion and pubic tubercle, that may be ilioinguinal in nature. So an ilioinguinal nerve block may be helpful. It's uncommon not to cut any nerves during a mesh removal, especially if you had the plug and the patch removed. Just the removal of the patch alone can cause ilioinguinal nerve injury. So first start with a nerve block to see if it's your ilioinguinal nerve. One more and then we'll see you next week. Okay, I went back to my implanting surgeon and he said to go to pain management. I knew right then I was screwed. Yeah, I agree. They just won't admit they messed up. I'm praying Dr. Fitzgibbons will help me. I was referred to him. Great. Still have tax in my pelvis and possibly leftover mesh. It's been 5 years since my removal and my pain is still off the charts. So best of luck to you. Definitely see the specialists that I have confidence in, who are the only ones that I bring on these shows. So good luck to everyone. I think I hope that this has basically been helpful. I have so many more stories to share. You can't imagine how many stories I hear every week. It's just something that I love to hear, and I feel it really is a great part of what I do every day. So in summary, be your own best advocate, share your stories, make sure your doctor hears your story, and never not believe in yourself because you're often right. And on that note, love you guys. Thank you, everyone. I will see you next week. We have a really great series of people that we have lined up for the next month. Hope to see you then. Bye.